Onc Live Insights is a video editorial program produced by Onc Live.
I'd like to just take a moment to tell you a bit about my own clinical practice. For the last 30 years, my life has been dedicated to study and treatment of patients with myelodysplastic syndromes. So my experience of MDS patients is slightly different than an average hematologist who's practicing out there, who'll see maybe a handful of cases a year. In my case, I see approximately 40 to 50 MDS cases, if not more, every week. And 2 to 6 of these patients are brand new patients that I see every week. And so when you see that many MDS patients for that many decades, you have seen it all. You've been there, you've done that. And in addition, then you are able to appreciate the nuances and subtleties of chronic morbidities that appear in these patients, because you're following some of these over decades yourself. And as they go from being transfusion independent to slowly becoming transfusion dependent, to having more and more transfusions, to developing iron overload and then consequences of iron overload, and eventually dying, when you see that entire cycle unfold in front of your eyes, that is an education that only comes with experience and observation of years and years. I would like to describe one of my own patients as a perfect example of how and why iron chelation therapy is so critical. So I have a patient with lower risk myelodysplastic syndrome, refractory anemia with ring sideroblasts to be exact, who is in his late 60s. And this patient was treated first with recombinant erythropoietin, then with hypomethylating agents, then with immune modulatory drugs, and did not really have the greatest of responses and has remained transfusion dependent throughout. And throughout, I spoke to this patient about the need for iron chelation, but he was one of those non-compliant nightmares that we all face every now and then, and would take the chelation for a bit and then give it up and find 100 reasons why he wasn't taking it. And so it so happened that he now has received something like in excess of 75 blood transfusions over a period of a couple of years, and suddenly ended up in the emergency room in acute heart failure with a heart rate of 180, in atrial fibrillation and risk of imminent death. We had to admit him to the coronary care unit. Cardiologists are involved. The T2 star MRI showed immense iron overload, literally a cage of steel around his heart. So it was one of the scariest MRIs that I have seen. And this patient had to remain in the unit for 6 weeks fighting for his life. And we had to initiate aggressive intravenous as well as soon as he was able to take oral iron chelation. And by the way, there has been some synergy that has been described between desferol, which is the intravenous chelator, as well as feriprox, which is the oral one. And only by aggressively chelating this patient, interestingly, even as we are continuing to give them blood transfusions, but just the aggressive chelation, which brought down his ferritin level from over 7,000 to lower ranges, was he able to come out of the CCU and ICU after 7-8 weeks sojourn there, and was eventually able to go home, and now has really understood the importance of continuous chelation. So this is one of those extreme cases that I wanted to describe, because here is the perfect example of why we as hematologists would be kicking ourselves if we hadn't been chelating this patient aggressively all along. And so I feel very strongly that for lower risk MDS patients, the best advice we can give those who are getting chronically transfused is to take the issue of iron chelation seriously.